Hello there, I'm Tony Meekum. This is the third video in the anatomy review series, and this is just a quick panoramic review. So same drill as before, you've had pano in your first year course, DMD 5340. I'm not going to reteach geometry, focal trough, physics of magnification and distortion. You've had all that. So if any of this feels unfamiliar, that's your cue to go back to the first year material before continuing in this course. It's foundational for clinical interpretation. The Canvas quiz you'll also see is going to check on how well you're doing with this. If you do want to go back and review my previous videos, I have a more detailed panoramic video as well. What I want to do here is focus on what matters most for this course, recognizing panoramic anatomy, recognizing one important artifact, the ghost artifact. So really going to focus on those two things. So let's get started. So real briefly here, the thing you need to recognize about ghost images in panoramic imaging is it's any object that's between the source of X-rays and the image plate. That's what's represented in this diagram here. So remember, the X-ray source rotates around the patient starting from the front right while the sensor's on the opposite side, and they move around the patient like that. And so that's what these little diagrams are representing. And so what's creating a ghost image here? If it's between the source and center of rotation, this is the X-ray source, that's the center of rotation. When you're first starting to generate the image, maybe the mandibular angle, the mandibular ramus, things between those two structures are going to cast ghost images on the opposite side. And then here when you get halfway through the image, well, anything between the point of rotation and the X-ray source. So here's where you get the ghost image of the spine, and it projects over the anterior part of the image. And then when the image is finishing up, you're getting a ghost image of the left side of the mandibular ramus and the angle. So some other rules you need to know. First, the ghosts float, meaning X-rays are coming from below and they're projecting higher. So a ghost image is projected even higher on the opposite side. So ghosts are higher than the real object. The second thing is ghosts are blurred horizontally. So if you see something stretched out and not in focus, maybe suspect that that's a ghost image and not a real image. Common ghosts that you'll see all the time is the opposing mandibular ramus, the spine, the hyoid bone, metal objects like earrings. Hopefully those are all taken out when you take a panoramic radiograph. But anything that can be in this area right here in the orange is what creates ghost images. Okay, so on to panoramic anatomy. Going through the key structures pretty fast. Same approach as intraoral. Identify it, name it, move on. So if you can't identify it during this video, do your homework. All right, so what's this well-defined inverted teardrop shape? Posterior to the maxillary sinus, aligns with the posterior wall of the sinus. In fact, that's the anterior border of this structure. This is the pterygomaxillary fissure. That fissure is the opening into the pterygopalatine fossa. All right, in this image, there are two well-defined corticated lines. One is the real image of the hard palate. One is the ghost image. So which is which? Remember the tip about ghost images? The ghosts float as they project to the opposite side. And so this is the real image of the left side. We're always talking about the patient's left or right. This is the ghost image of the right side that's a little bit higher. You'll see this all the time. Definitely need to recognize it. All right, so this asterisk is indicating a radiolucent area here in the inferior portion of the mandibular body. What is that? It's inferior to the molars. Sometimes it extends inferior to the premolars. And I showed this in intraoral as well, but this is the submandibular fossa. That's where the submandibular gland sits. A lot of fatty tissue in there. As the bone develops around it, it develops this fossa. So be aware as well, there's often sparse trabeculation throughout this region in the inferior portion of the mandibular body. So don't assume pathology just because you see radiolucency throughout here. Here are all the structures everyone should be able to identify on a pano. Know the maxillary sinus borders, be able to trace them, and get in the habit of doing this. Always trace the sinus borders carefully. Know my favorite anatomical structure. There's a couple reasons I like that one. I'll always test on it. Don't mistake that for the posterior border of the maxillary sinus, because if you do mistake that, you may miss pathology. If you see destruction of any of these borders, it could just be infection, or it could be a sign of squamous cell carcinoma of the maxilla or other malignancy. So you could potentially be saving someone's life. The trick with the zygomatic process of the maxilla is if you want to find the posterior border, you should follow the maxillary tuberosity upward, and that should direct you right toward the posterior border of the maxillary sinus, also the anterior border of the pterygomaxillary fissure. You may also see sinus septations in panoramic radiographs. Those are normal anatomical variations. What else didn't we cover? Infraorbital canal. Those cross the inferior border of the orbit. A lot of times you can see the pterygoid plates in a panoramic radiograph as well. Sometimes they're very discrete, and other times you can't really see it at all. All right, what about soft tissue structures? Do we need to be aware of soft tissue structures in pano? Absolutely. And what is this large purple thing if you compare with the actual panoramic radiograph up here? Is that really the tongue looking that huge? Yeah. The tongue sits on the point of rotation for a long time during the scan, so it gets horizontally stretched. It looks ginormous. Between the tongue and the soft palate or the hard palate will be an airspace, so the palato-glossal airspace. If done ideally, you have the patient suction the tongue to the top of the mouth and you won't see this, but a lot of times that's tough for patients. They don't really understand what you're saying, and so frequently you're going to see that air gap. The hard palate line should connect posteriorly to the soft palate. The soft palate ends in the uvula. Earlobe sometimes shows up superimposed where the uvula is. Usually it's further back though, but that confuses a lot of students. Sometimes you see it superimposed with the styloid processes. Then what about the nasal turbinates? They look huge as well. Because they're kind of toward the midline of the image, they get stretched out. So think of everything midline in a pano is really being stretched out to form onto this two-dimensional radiograph. The middle meatus is this small radiolucent line between the inferior and the middle turbinate. And sometimes that's very distinct and looks like it continues all the way across the midline. The nasal septum should be easy. Usually pretty straight, although it's pretty frequent that you get deviation of that nasal septum. And so you can see some of the hard tissue component, a lot of the cartilaginous component. And so you have the soft palate. Above this, you have the nasopharynx, and below it, you have the oropharynx. Following down, you see the epiglottis, which is indicated by the black arrow here. It's a cartilaginous structure that helps you swallow and breathe, hopefully not both at the same time. That's kind of the whole point of the structure, is to have you do one at a time. But it does not have a cortical outline because it's just a soft tissue, but a very cartilaginous structure. Then do you see the hyoid bone? It's horseshoe in shape, and in a panoramic image, you're seeing it from the side. So you see the hyoid body. A lot of times it projects over the mandibular body like this. And then the greater cornu of the hyoid bone projects posteriorly. And the ghost image of the other side kind of stretches across it like that, going off the lateral portion of the image. So don't call this the clavicle. I've seen students do that. I've seen experienced dentists do that, but you're never going to see a clavicle on a pano. Hyoid bone up here where it might be captured in the image. Clavicle, not so much. So that's guaranteed wrong if that's a choice on an assessment. Sometimes like this, you'll see calcification of the superior horn of the thyroid cartilage, because the thyroid cartilage comes right up here beneath the greater cornu of the hyoid bone. And then also you'll see calcification of a small round piece of cartilage called the trapezial cartilage. Both can calcify. Really think of any cartilage in the human body can calcify over time. And it's worth flagging now, the reason you want to identify all of these, because you could see carotid calcifications in a similar area. You need to be aware of what these thyroid cartilage and the trapezial cartilage looks like, because the carotid artery can calcify anywhere around here. Usually it's more irregular when you see arterial calcifications, and we'll get to that. So just like I did with intraoral, here's your list of 30 structures to identify on a panoramic radiograph. Use this as a checklist when you're studying, but this is not comprehensive. There may be a few things you see in books. There may be a few things I refer to that are not included in this list. And so hopefully you're familiar with even more than these, but make sure, at least as a starting point, you're familiar with all 30 of these structures. Specifically number 30, remember that's my favorite one, ZPOTM. All right, on to panoramic quality and positioning errors. So ideally you have your patient sitting straight up, nice and tall with a long neck. So don't make them like Ralphie here, or they're going to have neck pain, as well as give you a terrible image. There are a couple of diagnostic killing errors. The first one is if the chin is up too high, then the hard palate line superimposes the maxillary roots. And you don't want that, because then you can't diagnose the maxillary teeth. So my little rule of thumb is make your patients happy, because when you do that, they have a kind of a gentle smile line. But don't make them too happy. Don't give them like a Joker smile line. We'll show you some examples here. See, this one is just on the verge of too happy, but I'd rather see this nice smile line than have it with the chin up. See how now the hard palate line gets kind of projected superiorly to the apices of the maxillary teeth? And so that's okay. It's better than the alternative. Let's go through some of these. What's wrong with these? Of course, always, always, always take off the glasses, take off any earrings, anything that can come off that's jewelry, anything made of metal especially. But even like me, if you got plastic glasses, you want to take those off as well, because a lot of times those have screws inside of them that will show up. So any removable items on the patient's head, what about necklaces? Yeah, I would say just take those off as well. If they could tuck it down to where it's down below a shirt collar line, it might be okay, but just by default, remove necklaces as well. Any jewelry. And so this is the one I already mentioned. If the chin is up, the hard palate line gets superimposed over the upper teeth. That's bad. What about too far forward or back? Well, if I'm too far forward, meaning the anterior teeth are not in the little slit that they belong in, but too far forward, well, because of magnification and minification in panoramic imaging, the anterior teeth are going to be narrowed if too far forward. You'll probably also see a lot of the spine. But if they're too far back, so the teeth are not in the notch, but it's back behind that bite notch, then those anterior teeth are going to appear widened and you may cut off the condyles. Anything else? These I think are pretty self-explanatory. When a patient's tilted, you can tell that right away in the image. This one may not be quite as obvious. When a patient's turned, if I'm turned to my right, usually what that means is my right teeth are brought closer to the point of rotation and they're widened, they're magnified on the horizontal angle. And the other teeth, the left side looks squished. It is a little bit different whether I turn and move my midline versus keep my midline stable and then turn that direction. If you can imagine that, then these teeth are actually going away from the point of rotation. But really, I just want you to recognize one side wider than the other. That means the head was turned one way or the other. Slump position, that means the patient was sitting out here and you made him lean forward. And then the ghost image of the spine gets really dense and it projects right over the teeth. It's really hard to see this teeth. So really what you're looking for slumped is a very intense ghost image of the spine. What about this one? Are these anterior teeth narrowed or widened? That's your hint. They're narrowed. So what does that mean? Narrowed is too far forward. It's more forward than the focal trough, so they get compressed laterally. They're also kind of blurred because they're not right in the focal trough. I would say the chin is down a little bit. That would be a second error. But teeth too far forward is the main thing. And because of that, you see more of the ghost image of the spine. Teeth too far back, and now these anterior teeth are widened. And that's what that would look like. Here's the bite notch, here's the teeth. I'm just going to go quickly through some of these. Nice flat occlusal plane in this one. This is pretty ideal. Here we even have lines directing you. The chin is up a little bit. And what does that do to the hard palate line? Even just a little bit of kind of head back, chin up creates that hard palate line to project over the root apices of the maxillary teeth. So you can see why that's a bad error to do. What about this one? Chin up again, right? You see the hard palate line? Even though it's just a little bit, it affects diagnosis. In this case, the chin is down. This one, the lines kind of show you. Head is tilted this way. In this case, what's off? This is off from the midline. So the head is rotated to the right, actually. And if you compare the size of these molars, this first molar is really wide. That one's not quite so wide. And so that's some head rotation to the patient's right side. This was a tough one because the patient's midline isn't perfectly aligned. The teeth are kind of skewed to the side. But again, this is rotation. If their skeletal structures are aligned to the left, then in most cases, these right teeth are going to appear wider than the left teeth. What is this one? What did I say about the ghost image of the spine being very opaque and overlapping specifically those mandibular teeth, but the anterior teeth, the patient is slumped. Here's another example. Pretty bad ghost image of the spine. If you have a patient, kind of turtlenecking like that, that's what creates the slumped appearance. This one looks pretty ideal. Sometimes it is tough to get the patient to keep their tongue against the hard palate. That's why you always say swallow. Keep your tongue suctioned on the roof of your mouth and leave it that way. Keep the mouth closed. Breathe through your nose. All those things can help avoid this. But if their tongue is down, it'll create that dark line. This is not the worst error to have, but sometimes if that's too radiolucent over the apices of the teeth, it does make it harder to diagnose. This one, hopefully easy to recognize. The chin is down too much and we're kind of cutting off the mandibular teeth. That's why they just kind of disappear here. It creates this illusion of a lesion in the anterior mandible. So be aware of that. Sometimes the teeth are just not right in the focal trough, and that's not always a pathological lesion. All right, that's it for panoramic anatomy. And just to brief review on positioning errors. Again, if any of this is not familiar, you've got other material you can go back to. You can look at my previous recordings on YouTube. I have some from 2025, some from 2021, and different years going more into detail of all these things. But that's it for now. We've been through the anatomy review. See you on the next one. Thanks.